Hi, and welcome to this 10-minute Tuts on an approach to upper GI bleeds. By definition, upper GI bleeds are any bleeds that have their source proximal to the suspensory ligament of Treitz, which is at the duodenal jejunal flexure. This involves bleeding from the esophagus, the stomach, and the duodenum. 70% of upper GI bleeds will stop spontaneously, 15% will have persistent major bleeding. It's important when you're approaching this patient to determine if it is due to a variceal or non-variceal cause, and patients can have different bleeding manifestations. They might have hematemesis, which can be frank and severe ongoing bleeding, or can be coffee grounds, which is when it looks like black coffee powder in their vomit, and this usually represents a limited bleed or bleeds that are resolving. The patient might have melena stool, which is typically black, tarry, and sticky, and this is due to altered blood. Melena stool indicates bleeding from the upper GIT that is then passed through the digestive system. And we talk about three different types of melena. There's fresh melena, which is jet black with a sheen to it. It's tarry and it's non-particulate. It's almost liquid in consistency. There's stale melena stool, which is blackish gray and can be dull and mixed with normal stool, and it's occasionally particulate. And then there's something called iron stool, which has a greenish hue to it when you rub it between your gloved fingers. And this is typically gritty or particulate. The way you can differentiate between these is if you take a gloved finger with some of the stool and you stir it in a cup of water, melena stool will typically dissolve completely with no sedimentation, and the water will turn black. But an iron stool will sedimentate and will turn the water green. So that's a handy way to differentiate between what type of melena stool you're dealing with. Finally, we also talk about hematochezia, which is when there's red or maroon blood in the stool. So this is blood that hasn't been digested and broken down, like melena stool. And this is usually due to a lower GI bleed, but can occur in massive upper GI bleeds associated with orthostatic hypertension, when it's just large volumes of blood moving through the digestive tract. So when you're questioning your patient who has an upper GI bleed or getting collateral from the family, you need to ask about the bleeding, ask about the bleeding type, quantify the volume if you can, and for how long it's been going on, what duration. Then ask about if there's any pain, where the pain is, what the nature of that pain is, how long the patient has been experiencing pain, and if there's any relieving or aggravating factors. Investigate any important risk factors such as NSAID use or liver disease, smoking history, or a history of ulcers. And look for any important complications such as tachycardia or shortness of breath, fatigue, or symptoms and signs of heart failure. When coming up with your differential, it's important to know the following features associated with common causes of upper GI bleeds. In peptic ulcer disease, which accounts for 50% of upper GI bleeds, patients will typically have recurrent, well-localized epigastric pain. This might radiate to the back or the shoulder if there's any diaphragmatic involvement, and they might have water brash, which is excessive saliva. A gastric ulcer will typically have pain that is worsened with food, whereas a duodenal ulcer will have pain on starvation, and this pain is actually relieved by food. So this is an important question to ask your patient. It's also possible to have ulcers in the esophagus, which might present with dysphagia, with reflux and odonophagia. And then there's something called a mammillary vice tear, where the patient will experience retching and coughing before vomiting, and this is due to a laceration at the esophageal gastric junction due to forceful vomiting. So the patient might have a history of vomiting or coughing or retching, and then the hematemesis occurred after. In patients where you suspect a malignancy, important features to look out for would be associated weight loss. That's any weight loss of more than 5 to 10% of their body weight without trying in a relatively short span of time. So not over 2 or 3 years, but more over like 3 or 6 months. And if the patient experiences any dysphagia in the esophagus. So again, our approach is to work out whether this upper GI bleed is due to a variceal or non-variceal cause. And if this is due to a variceal cause, your patient might present with jaundice, ascites, encephalopathy, and other stigmata of chronic liver disease and portal hypertension. In the South African context, hematemesis following acute gastritis due to alcoholism is a common cause of an upper GI bleed, accounting for as much as 30% of upper GI bleeds. So don't forget to take a good alcohol history. On examination, it's always important to make sure that your patient is hemodynamically stable. On general exam, they might have anemia, they might have jaundice if this is due to a variceal cause or edema, or they might have a Verkows lymph node if malignancy is present. Also assess if there's dehydration due to all the vomiting and fluid losses. When you take their vitals, Look out for a tachycardia or low blood pressure due to hypotension and hypovolemia. And when you do an abdominal exam, assess, is there ascites? Is there caput medusa, spider nevi? Are there any masses present? Check for hepatomegaly and also assess the liver edge. And as always, if you don't put your finger in it, you put your foot in it. So do a DRE, a digital rectal exam, to assess the stool color and look for melena stool. So what investigations are we going to do for our patient with an upper GI bleed? Well, at the bedside, we could do an arterial blood gas, and we might consider doing an NGT for nasogastric lavage, which usually confirms an upper GI source of bleeding if you're in any doubt. When it comes to our lab investigations, we want to send away blood for a full blood count as well as a UNE. Importantly, you want to look at the urea, because a urea that is extremely high relative to the creatinine is very suggestive, in fact diagnostic, of an upper GI bleed, because the breakdown of blood will raise the urea. You also want to send away for a liver function test, especially if the patient has portal hypertension or varices, as well as an INR, PTT, PT, because of the association with coagulopathies and bleeding disorders and liver dysfunction. In terms of our imaging studies, we want to do a chest and abdominal x-ray to check for perforation under the diaphragm, check that there's no aspiration of blood, and look for other important features that you might worry about with your sick patient with an upper GI bleed. A G-scope is very important for patients with upper GI bleeds because they allow you to stop massive bleeding using a Senk, Stake and Blakemore tube, or to use sclerosing agents or banding of varices. And if nothing can be found on the scope, then you definitely want to send away your patient for a CT scan. In your acute management of patients with an upper GI bleed, you want to start with the basics. Give them intravenous fluids, attach your monitors, and O2 therapy as required, and then assess their blood pressure for their hemodynamic stability. These patients may have lost a lot of blood. Do not give these patients anything orally. In fact, all your medications should be IV. These include a proton pump inhibitor, H. pylori eradication, cyclocapron or tranexamic acid, and prokinetics to help empty their stomach so that there's less force to their vomiting. You also don't want to forget to send away blood for a cross-match. What are the conditions for blood transfusion in these patients? An immediate indication for blood transfusion is if your patient remains shocked despite fluid resus. No questions asked, they will get blood product. If the patient has a hemoglobin of less than 9 and they are elderly, or they have coronary heart disease, or their hearts are not going to be able to cope with working to account for the loss of volume and the loss of blood pressure, these patients qualify for blood transfusion. But if you have a low risk patient and they're pretty stable, as long as their HB is above 7, there's not an immediate indication for blood transfusion. However, you will assess clinically, of course. And don't forget that if you're administering large volumes of blood, you want to include fresh frozen plasma for the coagulopathy, because they're using up all of their clotting factors. They're using up their pathways to try and stop this bleeding. Be careful if you're transfusing patients with heart failure or with renal failure. Remember that this blood product going in is extra volume. For every single patient with an upper GI bleed, your consultants, your seniors, and your referring hospitals will want to know what the patient's Glasgow-Blatchford scale score is. This is a scale that includes systolic blood pressure, hemoglobin, urea, and other markers to assess their bleeding risk. And if the patient's score is more than 6, that requires immediate intervention. The Glasgow-Blatchford bleeding score is a very important component of managing these patients, and you can find it for free at MD Calc or within the MD Calc app. As discussed, upper GI bleeds involve the esophagus, the stomach, and the duodenum. So you need to come up with the following differentials. In the esophagus, this might be due to varices, might be due to mammary vice tear, especially in the case of binge drinking. It might be due to ulcers, infections, malignancies, or an arteriovenous malformation. In the stomach, the most important cause would be peptic ulcer disease, but also there's malignancies and gastritis. And again, as we said in our context, a common cause of hematemesis is due to post-alcohol gastritis, or patients might have a bleeding stomach polyp. In the duodenum, again, peptic ulcer disease is a very, very important differential, as well as malignancies, polyps, or an arteriovenous fistula. Other causes not directly in the alimentary canal itself are coagulopathies or an aortoenteric fistula if the patient has had recent aortic surgery, and also, of course, ENT bleeds. where something is bleeding in the throat and going down the esophagus into the stomach, and the patient presents with hematemesis, and you might think that this is a GI bleed, but actually it's something in the throat or in the head, and the blood is just going down into the esophagus and presenting that way. Finally, in our surgical management of upper GI bleeds, which is a little bit outside of the scope of what a junior doctor or medical student will do, there are various techniques to manage these bleeds. The first is injection with adrenaline or a sclerosant, which will constrict the blood vessels so that they can't bleed anymore. There's also thermal ablations with heater probes or bipolar probes that ablate the vessels. It's also possible to clip vessels, and there's a variety of techniques. Some are through the scope, some are over the scope. As long as you know that there exists, that's typically sufficient for a medical student or a junior doctor's knowledge. And there's also new techniques involving hemostatic powders as well. I hope you enjoyed this 10-minute Tuts with a brief overview and approach to upper GI bleeds. If you found it useful, please hit the like button and subscribe, and don't forget to have a great day.